Hi, good evening, everyone. Welcome back to another session of our webinar. I think we have done almost 6 to 8 sessions with the Beacon, and I think this is the last one. It's been amazing. It's been overwhelming. The response to this talk alone, I think 400 over people registered for this talk. So I worked very hard yesterday to send off all the emails for the Zoom link. Anyway, we'll welcome Dr. Ham Man Chin, who is actually the radiologist in Beacon Hospital, to give us a lecture on X-ray interpretation of both abdominal and chest X-ray. So without further ado, yes, Man Chin?
Yes. Hi, everyone. Good evening. So I'm Dr. Ham. Should I share my screen first? I'm sorry.
Yeah, that's right. You share your screen first.
Yeah. Hold on.
Okay, good. I hope that everybody can mute themselves.
Can see clearly, right?
Yeah. Okay.
Hi, good evening, everyone. So I'm Man Chin from Beacon Hospital. So I would like to share with you guys a presentation about chest X-ray and abdominal X-ray. So we will target about the interpretation to identify the normal, then only we identify the common and subtle pathologies on chest X-ray and abdomen X-ray. And first of all, I would like to thank Dr. Betty for inviting me to become a speaker today. So in between, if you guys have any question, you can stop me or put in a question in chat box. I will try to explain and answer your questions.
Man Chin, you can also ask them questions so that it will be more interactive, because sometimes they can be quite amazing at reading X-rays. We have one session, yeah. Maybe we can also try to do that, yeah?
Okay, sure.
Okay.
So let's start. So the outline for the talk today will be how to approach a chest X-ray, and then we need to recognize the normal. After that, we need to describe the expected chest radiograph finding, which are the common findings that we always encounter. And then next we go to the mediastinum. I tell you some about lines and stripes, and then the common differential diagnosis of mediastinum masses. And then next we'll look at some X-ray regarding pleural abnormality. And then after that, we go to abdomen X-ray, some simple approach, and then the normal abdomen X-ray, and also revise about some expected findings like bowel obstruction, the common abnormal that we encounter in our clinical setting. Okay, so X-ray is the commonest form of imaging and the modality which all doctors should know how to integrate. Then we should have a systemic approach to when interpret the X-ray, so we won't miss any findings. Okay, and then always find the previous or old X-ray for comparison so that we can identify if there's any findings changes. And then again, the detailed clinical history, physical examination, and related biochemical findings are also important, especially when clinician they request an X-ray, they need to give us this information so that we can correlate clinically. If not, I will ask back the clinician to correlate that stuff. Okay. So
Man Chin, can you make the slide into like a full slide instead of the next slide?
Okay, hold on now.
So that we can see it clearer.
Okay.
Okay, go to slideshow and then
Sorry,
from current slide. From current slide.
From current.
Yeah.
Is it better now?
Yeah, I think so. Yeah.
Can see full screen?
Yes. Full screen.
Okay. Can right now?
Yeah.
Okay. So this is the X-ray just showing some common artifacts that we can encounter. So you can see a lot of lines here. These are due to grid artifacts. It's a technical error, basically. So the next will be, this is an example of hairline artifact, where you can see there's some linear shadowing on top of the chest, this one, the upper hemithorax, and also at the neck region. Can you all see the full screen? Sorry.
Yeah, I think it's full screen, right?
Yeah, can see, right?
Yes.
Because I
This
have
is full
the-
screen.
Yeah, it's full screen.
It's right. Okay. Oh, I know. Okay. So can you see the curvilinear opacity here? So
Yes.
these are the hairline artifacts. So when we see all these artifacts, we must know so that you won't misinterpret as some lesions. Okay. So we must always remind the patient to tie up their hair when doing the X-ray. Okay, so next we're going to basic step quickly. So there are many ways of approaches to interpret an X-ray. I would like to use like inside out or outside in approach, or some will use ABCDE with some mnemonics. Okay, so for chest X-ray, in inside out approach, we'll look at the heart first, go to mediastinum, then hilum, go back to the lung, thoracic wall, then always look at the included abdomen in the X-ray. Okay, but myself, I like to use outside in approach. I always look at the thoracic wall first and going to lung, then only going to the center of the X-ray. So from there, we can identify any abnormality and then identify the pattern and also the differential diagnosis. So ABCDE approach, these are examples that you may opt to. So airways, A, look at the trachea and then the carina and also the hilar point, both sides. Next, B, breathing, look at the lungs, feel both sides, and also the pleura at the edge of the chest wall. At the edge is the area we look for the pleura. Next will be circulation, look at the heart, make sure the heart size is okay, and also the great vessel shadows. And then next, go to the diaphragm, lower part here, and also the costophrenic angle. And then E is everything else, bone, soft tissue, or external. Okay. Then the rest are upper abdomen region, the area under hemidiaphragm. So again, check the name of the X-ray. This is the must step, because sometimes we might interpret wrong X-ray for a wrong patient. Okay, check the patient gender as well, and then look at the left and right marker before we start. Sometimes the radiographer might accidentally misplace the marker. Okay, especially when we find that if there is dextrocardia or not. Okay, next we look for the extra object like central line, ETT, any NG tube, or any external artifacts. Okay, so these are the difference of radial density appear differently on X-ray. So we start from the air. So air, the X-ray can penetrate through it, so you won't see anything. So it will be black. So especially you can see at the edge of the film, this is very dark. So this is outside the view. So inside here, because we have lung field is full of air, with in between there's some pulmonary vessel, so we can see a fairly dark area of lung fields. Next will be fat. Fat will be less opaque. So you on the soft tissue, then you will see this kind of fat is grayish. Next is soft tissue. The muscle is more brighter. Then going to the bone is dense, and the most dense material will be metal. Look like this is the implant. This is very dense. Okay, these are different in radial density appear on X-ray. So next we will have to assess the X-ray whether it's good exposure or underexposure. These are the examples showing overexposure where you can see the lung field is very dark. So from here we might miss some vision. Then the other one is underexposure will be very bright. We also might miss some vision that hiding at the periphery of the view. Okay. So again, when interpreting the X-ray, first check the centering point of the film. How do we check? So first, identify the spinous process of the vertebra. The medial end of the clavicle the distance between the medial end of the clavicle with the spinous process should be symmetrical both sides. So either one is lesser will be rotation. Okay, so this is the first point. Next, assess the penetration like just now. Then the lower thoracic vertebra, this region should be visible through the heart shadow. If it's like this case, if it's under, then we cannot see the spine. If it's over, we will see further of the spine. Okay, then check the lung volume. So we always know that the midpoint, the right hemidiaphragm should be in between the anterior end of the 5th and 7th rib. So we count the ribs in 1, 2, 3, 4, 5, 6, 7. So must be always in between the 5th and the 7th rib. This is more than that is hyperinflated, is less than that is under inspiratory firms. Okay, next look at the pulmonary vascular pattern tissue, that including hilar and then costophrenik angle. So the dividing zone, I will explain it later. And then review the blind spot, which are always the important review area. Look at the episodes specifically, in case we miss some Pancoast tumor. Next, look at the retrocardiac region. And then next, look at the retrosternal area and the mediastinum here. Okay, after that, go to the trachea to see whether it's patent, which we show as a loosened lumen here, and then the left and right heart border. After that, we need to measure the cardiothoracic ratio. Normal will be 0.5. Then the last step will be look at the bone and the surrounding soft tissue. So these are the hidden area that we must always look for when we interpret the X-ray. The apical, the hilar region and the mediastinum, the retrocardiac region here, and also the under the diaphragm. So this is an example of good PA view X-ray. So first, it is center, then the clavicle are horizontal, then the scapula is outside the chest wall, so it's not obscuring any lung fields area. Okay, and then the spine and the posterior ribs here are clearly visible. And then good inspiratory, like how we interpret just now, the midpoint of the hemidiaphragm should be between the 5th and 7th anterior ribs, or 6 or 10 posterior ribs. So these are the difference between PA view and AP view X-ray. So you can see the AP view X-ray, the heart is always magnified. So if we want to assess the cardiothoracic ratio, we might not be so accurate on AP view. Again, this is X-ray showing the anatomy. I just ran through. So this is a trachea. After the trachea will be the carina. And then this is the aortic knuckle. After the aortic knuckle, here will be the pulmonary artery. And then descending thoracic aorta outline. Left ventricle forming the left heart border. Right atrium forming the right heart border. It's not the right ventricle, it's right atrium. The right ventricle will be sitting in between here. Okay. And then the costophrenik angle again, the hemidiaphragm again. Okay. These are examples showing oblique view and lateral view X-ray. Oblique view, we always do if we want to look for ribs fracture. Okay, if not, we rarely do oblique view. These are additional view. Then lateral view also we seldom do if specifically want to look for retrosternal lesion or retrocardiac lesion, specifically, or any hilar lesion. But normally nowadays we will proceed to CT actually. Okay, so to dividing zone will be upper zone, middle zone, and lower zone according to this diagram. So for the upper lobe, then we will know the upper lobe is on the right side, right upper lobe. So we have 2 lobes on the right and 3 lobes, 3 lobes on the right side, 2 lobes on the left side. So upper lobe, then the right lower lobe will be overlapping with the upper lobe on AP view, as you can see in these 2 diagrams. And then the right middle lobe is overlapping with the right lower lobe and on frontal view X-ray. So if want to further determine the lesion arising from which lobe, you can do additional lateral view. Then you can identify the location of the lesion. Okay, these are the location of the fissure, the major fissure, the oblique fissure obliquely, and then the transverse fissure horizontally. So for the left lung, we only have 2 lobes, the upper lobe and the lower lobe. So on frontal view X-ray, both of the lobes are overlapping always. Okay. So first of all, this X-ray, we are showing dextrocardiac because the marker is correct left and then right, they specifically label it. So if it's not, I will always check with the radiographer whether if there's any rotation or mirror imaging while doing the X-ray. Always check with them. Okay. So now we're going to interpretation of the some of the common pathology include these are the right upper loop collapse. So when determine right upper loop collapse, we always use the sign of golden S sign, where you will see an opacity at the right upper zone here. And then this is the border of the upper lobe. This is the lower lobe. So we see a slight S sign here. So we call it golden S sign. There's associated features of elevation of right hilum always. Okay, remember this. So always interpret there's opacity here on AP view, and then the golden S sign here, and then associated with elevation of the right hilum. So of course, when there's upper lobe collapse, there's also tracheal deviation to the right side. Next is middle lobe collapse. Middle lobe collapse will have specific features where we will see increased density at the right mid zone, and then the rest of the right lungs will look blacker or darker than the left lung. Okay, so you will see an opacity here. It will obscuring the right heart border, and then on lateral view, you will see a triangular shape opacity, okay, overlapping with the heart shadow. This middle lobe collapse on the right side. Then next we go to right lower lobe collapse. You will see a significant, significant, this one is the triangular shape opacity overlapping with the right heart border. This is always pathognomonic for right lower lobe collapse. Then on lateral view, you will see opacity at the posterior of the chest wall. So again, on frontal lobe, rarely we do the lateral view. So we look at the frontal view, you will have a triangular opacity overlapping with the right heart border. This is right lower lobe collapse. Next, we're going to left upper lobe collapse. This is a special case because it's different from other collapse. You will see opacity, but this one you will see wheel-like opacity. So some of us might miss these findings if we are not looking it closely. So when we have an X-ray, we need to sit further a bit. So look at the chest wall, the lung field, both sides, and compare the density. So in this X-ray, you will see the whole left lungs, right, is slightly radial opaque compared to the right. So this is what we call wheel-like opacity. It's just a slightly whitish, but you don't really see a opacity or mass unless the lung mass is quite big. Like this case, you can see it's like obvious. So next you will see we call Lufsical sign, where there is hyper expansion of the superior segment of the lower lobes, then overlapping with the mediastinal border. You will see this lucency here, we call Lufsical sign. But the most important finding is the wheel-like opacity. So we must always look carefully, if not we will miss this finding actually. Again, it's associated with elevation of the left hilum compared to the right side, and then there's also tracheal deviation to the left. Next, left lower lobe collapse, triangular opacity or shadow at the left heart medially. So this is example. This is a left lower lobe collapse. Okay. This is easy to identify, but some of us may miss it because we thought it's a heart border. Okay, that's why the retrocardiac region is always a review area. Okay, so I'll ask some question. How to get the participant to answer?
You ask a question and then we will put in they will answer in the chat.
Answer in the chat. Okay. So please type the answer for this X-ray and also this X-ray. Easy one.
Okay, so the X-ray on the left. Okay.
On the left-hand side.
Okay, we do that first.
Yeah, do you see my arrow? You can see my arrow pointing, right?
Yes, right. Okay. So we have answers coming in.
These are the easy one,
Yeah, very. You already. I also can answer, I think.
Everyone can answer.
So most have said right upper lobe collapse. So,
Yeah, it's correct. So this right upper lobe collapse, you always see an opacity at the right upper lobes here. Okay, so this is the golden S sign, although it's not so S shape. Okay, but it's golden S sign here. And then there's also, you can see an elevation of the right hilum. It's supposed to be lower down here. Okay, although the trachea is still not deviated yet. Okay, so now we go to the X-ray on the right hand side.
okay. Left upper lobe collapse. Okay. So,
So, okay, this left upper lobe collapse. So the findings is wheel light opacity. So everyone can identify wheel light opacity now. So always look at the lung fields, the darkness between both lung fields, okay? No one should miss the left upper lobe collapse after this. And then sometimes we can detect, so left upper lobe collapse always due to some bronchial lesion that obstructing the left upper lobe bronchus. So you might see a mass lesion here, okay? But to identify the wheel light opacity is very important. So I still remember last time when during exam time, we always miss this finding during the hot shift examination. Okay, so after that, we won't forget anymore. Okay, good. So what about this X-ray? On
okay.
the left-hand side?
On the left-hand side. Okay, so X-ray on the left-hand side. Maybe it's not just the diagnosis, but also the description of the X-ray on the left-hand side. Some description. Okay, so somebody said tension pneumothorax. So Claire said that, Joni said that. Lee said right middle lobe collapse. Okay, so we have more and more saying right lower, or we have right lower lobe collapse. Right lower lobe collapse.
Yeah, my question are very easy. We are always pairing right and left.
Okay, right middle lobe collapse with right tracheal deviation. I think the right tracheal deviation cannot be missed.
Yeah.
That one is really, I think the whole mediastinum is shifted to the
It's shifted to the right, actually.
Yes,
Actually,
so-
there's some rotation also. These are
I
X-ray,
see.
actually.
So somebody said a triangular right
Triangular
heart
shape.
body.
I think it's right lower lobe collapse, right? Not middle lobe.
Yeah, I don't know. You tell me.
Yeah, this right lower lobe collapse. Okay,
Okay.
let's go back to the finding just now. See, this is the right lower lobe collapse, always a triangular opacity. Okay, obscuring the right heart border. Okay, remember, so it's right lower lobe collapse, like here. Go back to right middle lobe. Right middle lobe, we will always see as some subtle opacity. We won't see the triangular shape. So remember, when we see the triangular shape opacity, is always right lower lobe collapse.
The middle lobe collapse actually
Very difficult to
blunt
see.
the cardiac shadowing.
Just
Yeah.
slightly of the cardiac shadow, but not the triangular shape. Okay, so the triangular shape is lower lobe. All right. So now, what about this?
Okay, this is okay. So the right X-ray now. Anyone? Everybody is doing very well. They're paying attention. Okay. Jia Jing Li said left lower lobe collapse. Yes, I think so. Yes. So most says left lower lobe collapse.
Yes, good. So this is left lower lobe collapse. Okay, again, the triangular shape at the retrocardiac region. So I guess after the presentation, everyone can identify the collapse very well. So, and always must remember, look at the retrocardiac region when we review the X-ray. Okay. What about this?
This is a right middle lobe collapse.
Yeah. So this is a right middle lobe collapse because slightly obscure the right heart border. But
Yes.
actually there's associated consolidation here. Okay, everyone can see the opacity. So
Yes.
this is right middle lobe collapse with opacity. Okay, what about this X-ray? This one is pathology, but not collapse. There's no collapse in the X-ray.
Anyone?
You can type normal,
wing,
there's normal.
bad
No,
wing.
there's no bad wing.
Somebody said normal, underexposed,
There's no collapse, definitely no collapse.
no collapse. Interstitial lung disease.
No. Look like it, but it's not. Some of our X-rays also look like this, interstitial, but actually normal because of the penetration of the machine. Good try, good try. Okay, so let's answer. If not, we cannot finish. Okay.
Normal.
So it's not normal. Ah, good. Who is Dr.
Somebody
R?
said left
Dr. R.
cortical opacity.
Yeah, so you will see some
Wow.
high opacity here.
So clever. Oh my
Also
God. Who is
you
it?
can see Dr. R.
Dr. R.
Yeah. So
Hey,
compare
great job.
both sides of the lung fields always. All right. So you can see this is slightly darker, but this is slightly opaque. It's very vague. Okay. Anyone can miss it, including me, myself. Okay. So to confirm, we do a lateral view X-ray, then you'll see opacity at the apical. So this is a Pancoast tumor. Okay. So now this one again. This is a consolidation. Where is the location of this consolidation? Is the location interpretation is almost similar as a collapse, but this one is appear as consolidation rather than collapse. So from here, we can interpret as lower zone easier and faster. If you want to be more accurate to tell the lobes, then you can try as well.
So it's
Anyone?
a middle lobe, right? Middle lobe.
No.
Okay.
So this is the right lower lobe consolidation. Okay, why? Because it's slightly obscuring the right hemidiaphragm, but the right heart border is not obscure.
I see.
So if middle, yeah, somebody answer, but no, the left side is okay, only the right side. Always remember, if something happen in the lower lobe, the hemidiaphragm will be obscured, but not the heart border. If heart border is obscured, if something happen in the middle lobe on the right side. Okay, so this X-ray right heart border is clearly seen, while there's some obscuration of the hemidiaphragm. So this is right lower lobe consolidation. All right. These are normal on the left side. Okay. Why not bilateral lobe? Because there's nothing in the left lung. Okay. Why not bilateral lobe? Can happen, but then it's not in this X-ray because you can see the heart border. Always identify the border. Okay, what about this X-ray?
Oh. Is it bat wings?
Yes. So Dr. Betty can answer most of the X-ray. This bat wing, this bilateral consolidation already obscuring the heart, maybe some the cardiomegaly, and also blunting of the claustrophrenic angle with some pleural effusion, pulmonary edema. All right.
Somebody said, can we say bilateral more than right side? I don't see why they keep on hopping on.
Yeah, where
the
is the consolidation? You see, I don't see any consolidation. Is it
And
here?
then the thing is, you see, if you look at your pathology, right? This looks like a lobar pneumonia. So if you look at clinically, I think you have to also think like, oh, this is a lobar pneumonia, but I don't see anything over the right. Sorry, the left, I mean.
Over the left, yeah, there's nothing on the left actually. Maybe this quality of this film a bit blur. Okay, never mind. But when you say opacity, you will really look at this kind of whitish opacity rather than a vague one, there is or there is not. Okay, when there is, there is. Okay, these are bat wing. Okay, so now we talk about lung nodule. Lung nodule is very tricky too because sometimes it's just granuloma or end-on vessel. So sometimes we might miss a lung nodule. So sometimes I also over reporting about lung nodules. Okay, but we ask for follow-up. So if lung nodule less than, normally I would say less than 1 cm, I will use the word nodule. More than 1 cm, I will use the word lesion. More than 3 cm is a mass, okay? And then if in the lung field, it won't touch the hilum or mediastinum. Next, later I'll talk about the mediastinal lesion. Then always not associated with pleural effusion, lymph node or atelectasis if there's solitary lung nodule. 40% are malignant, and then only more than 1 cm can be well seen on X-ray, okay? So these are nodule here on the left side, just as example, and then these are mass, okay? No one should miss this big mass here. So common cause for nodule include granuloma, lung CA, metastasis, but this always multiple, and or organizing pneumonia can happen very rarely, abscess or show as a lung lesion first or pseudotumor. So rare causes or less common, hematoma, mesothelioma, lymphoma. So always we don't give this kind of differential on our only X-ray, so we just put nodule. So stimulant of a solitary nodule or mass include nipple shadow. This is very common. I'll see it every day, and an artifact like composite shadow showing some nodule, but actually nothing there. Or cutaneous lesion or soft tissue, bony lesion, healing rib fracture, you will see a nodular appearance. Actually, it's just a callus formation, or pleural tumor or plaque. Can look at a nodule on X-ray as well. An encysted pleural fluid, we call it pseudotumor, or pulmonary vessel. End-on vessel can also be shown as a lung nodule on X-ray. So on this X-ray, you will see a lung nodule at the right upper zone. So here I only use zonal anatomy, is easier. So this right upper zone. Next, we need to do a CT scan. After you review this X-ray, you need to suggest for CT scan because this lesion is quite obvious here. So no need to think whether it's end-on vessel or granuloma. Like this kind of small dot, sometimes we might need to think twice whether it's worth writing it or not. But if you worry, just write it down and then next time follow up. Okay. So this is a malignant nodule, although on X-ray it looks fairly well defined, but on CT scan, then you will see this kind of we call it corona radiata sign. Okay, there's some fiber strand arising from the lesion. This is a malignant nodule. So if the nodule with a central calcification, like in this case, is always benign. Okay, always benign when the calcification is at the center of the lesion. While in this CT scan, you will see a dense calcification at the center with a fat density component here. So this is a hematoma. So when you see a nodule on X-ray, perform a CT. When you find the central calcification plus fat density here, why I know fat density? Because on my console, I can always check the radial density with just one button, okay? So if there's present, so it's confirmed hematoma, and with this nodule, no need for follow-up anymore, okay? So if there's eccentric located calcification, is always malignant. Just like this lung mass, without the calcification also I would think it's malignant because of irregular border and it's quite a big mass here. But on top of that, if there's eccentric calcification, is add on positive point showing malignant lesion here. Okay, so next we talk about cavity. So if less, the wall, always assess the cavity with wall thickness. If less than 4 mm, smooth, normally benign. Okay, can be just bulla or lung cyst. Okay, if malignant cavitation, we will have thick wall. Okay, if in between, then it's indeterminate. If irregular wall, likely malignant. If smooth wall, likely benign. Just percentage interpretation. Thick wall cavity, for example, small cell CA is always sometimes presented as thick wall cavity lesion. Metastasis also, then next will be abscess or pulmonary TB cavity or vaginal granulomatosis as well. So anyone can answer this X-ray, the easy one?
Okay. Lung abscess. Right lung abscess. Right lung abscess.
Okay, so these are lung abscess. So you will see a cavity here with a air fluid level. So no one should miss this diagnosis. Last time my lecturer used to say, if you miss this, it will be medical legal case. So scary. Okay. So air fluid level in a cavity, abscess, 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 and abscess. Okay. Good. Next is an egg crescent sign. So in a cavity, we will see some opacity within it, and like this one crescent shape lucency here. So it's called egg crescent sign. Always mycetoma first. Number one, differential diagnosis, aspergillosis. Okay. Rare cause will be hydatitis, blood clot, in a cyst, mucus plug in a cystic bronchitis. This is very rarely we will encounter. Rheumatism aneurysm is a pulmonary artery aneurysm associated with TB, gangrene, I never see one, or carcinoma arising from a cyst, very rare cause. So always egg crescent sign, cavity with soft tissue opacity within, mycetoma or aspergillosis, number one diagnosis. Okay, this kind of X-ray is commonly encountered in hospital setting, but not outside GP clinic setting lah. Okay, so for differential of multiple lung nodules, always multiple metastasis, number one. Miliary nodules will be tiny fine nodules, 1 to 2 mm in size. You will see very tiny dot throughout the lung field. Rheumatoid nodules, if there's clinical history of rheumatoid arthritis, then vaginal granulomatosis is one kind of autoimmune disease. Then staphylococcus abscesses also can present as multiple lung nodules. So what about this X-ray? Anyone can answer?
Cannonball.
Description for this X-ray?
Anyone? Cannonball lesion. METS. Okay, METS is the diagnosis. We want description.
Hey, can you hear me just now?
Can?
Can, okay.
Multiple malignant nodules. Is there something wrong with the bones?
Bones are there, some lytic as well. But now we focus on the lung first.
Okay. Patchy consolidation. I think it's definitely not consolidation.
Yeah, it's nodule, because now we are in the topic of nodules. Okay, so don't take this X-ray as consolidation. Normally, we won't have this much consolidation throughout the lung. Okay, always multiple lung nodules. These are example of cannonball metastasis. These are cannonball, a big round or oval shape, or some are lobulated nodules of varying sizes scattered in both lung fields. So this is cannonball metastasis. Okay, after that, you need to rule out the primary cause of the cannonball mass, most likely from RCC, renal cell carcinoma. Okay, so if you see this X-ray, you must refer to hospital and find out the primary cause. All right, this cannonball, not consolidation. Okay, so in this X-ray, so you will see an opacity at the left upper lobe here, or left upper zone. Okay, so we can interpret as, when you report the X-ray, we just say opacity at left upper zone. So next, we need to do CT to find out from where it's arising from. So this one just an example showing you, although on frontal X-ray, it looks like opacity arising from the lung, but when we do a CT scan, actually is from the this one, the scapular soft tissue mass here. Okay, so always projected on frontal X-ray, look like our opacity within the lung, but when on CT is external to the lung. So this is must bear in mind. But these are less common cause, and also we can diagnose it correctly because we have clinical history. But if it's not, then we will just say left upper opacity here. Okay. So this one is soft tissue mass, neurofibromatosis. So this one, this X-ray, easy. I think everyone should know, right? So these are pleural effusions, huh? Everyone must know, right? Pleural effusion, blunting of the costophrenetic angle with meniscus sign. Okay, so let's see how gross is the effusion both sides. Even when we see just little bit here, but actually when we scan through the ultrasound, we can see a moderate effusion already. All right. So no one should miss a pleural effusion, but sometimes a bit difficult and tricky where there's slight blunting of the costophrenetic angle in normal person. I always encounter as well. So I sometimes, if the rest of the lung fields are clear, asymptomatic, it might be due to pleural thickening. Sometimes when they do the X-ray, they're not taking the deep breath deep enough. Sometimes the costophrenetic angle will be slightly blunted as well, I noticed. Okay, so this one is a pseudotumor. You will see an opacity arising at the location of the transverse fissure. So always the transverse fissure will locate here. In most of the X-ray, we can identify the transverse fissure actually. So when there's opacity sitting along the transverse fissure, and if together with the blunting of the costophrenetic angle where there's already pleural effusion, these are likely to be pseudotumor where there's a loculated effusion along the transverse fissure. Okay, so this is confirmed on a lateral view X-ray. All right. So what is the diagnosis for this X-ray? Please answer.
Okay, anyone?
This easy one.
Pneumothorax. The left side, both sides the same, is it? Yes.
Yeah.
But the left side, is it tension pneumothorax? Cannot
Not yet,
say.
because cannot say yet because there's no shifting. Just to show pneumothorax with total lung collapse here, and then these are the moderate pneumothorax where you will see the pleural line here. Don't be surprised. Sometimes we can really miss this when we see this X-ray. Okay, so always remember, okay, how to identify pneumothorax? First of all, look at the pleural line. You can draw a line here. And then lateral to this line at this chest wall here is devoid of the vascular marking. So you will see this on the left side here, you will see the vascular marking extending to the periphery of the chest field. But here on the lateral to this pleural line, there's no vascular marking. So always use this point to say whether it's pneumothorax or not, okay? But on this X-ray, is very obvious there's no vascular marking at all, so it's pneumothorax, okay? If there is air fluid level within the pneumothorax, then we call it hydropneumothorax, all right? So hydropneumothorax, sometimes we can encounter when there's pleural effusion, post-tapping or post-drainage, they can have hydropneumothorax because then we introduce some air into the pleural cavity. So again, pneumothorax, identify the visceral pleural line, devoid of lung marking laterally. If there's associated with mediastinal shift or variable degree of lung collapse, then we need to assess whether it's tension or not, okay? So there's also some mistaking skin fold as a pneumothorax again. Sometimes we diagnose a pneumothorax actually is a skin fold, or even scapular border fold also can be misdiagnosed as pneumothorax. So again, look at the lung marking, whether it's extending beyond the line that you see or not. If there is, then less likely this is a skin fold artifact that simulating a pneumothorax. All right. So this is the border of the scapula. Also, we thought it's a pneumothorax, but the lung marking is still there, so it's not. All right. Next is nipple shadow. Always be sometimes be mistaken as lung nodule, but look at the symmetrical. Always at both lower zone. Okay, this nipple shadow, and they will have a fuzzy medial margin here compared to the lateral margin. Then these are nipple shadow. All right, but sometimes only single nipple can be seen, or sometimes we really not sure, so must always suggest repeat an x-ray with the nipple marker so that we can know whether that is nipple or not. Because got one time we thought it's a nipple shadow, but actually it's a lung nodule. Got one time, so the lung nodule grew bigger after a year when the patient come back for follow-up for some another time of screening. Okay, so if it's easy for us to diagnose when there's symmetrical nodule at both lower zone, always remember medial border is always fuzzy if there's nipple shadow. Okay, again, these are the example x-ray showing nipple shadow, symmetry, bilateral, and then in both lower zone here. Okay, next is this is end-on vessel. Sometimes we might mistaking this as a lung nodule, but if there is accompanying bronchiole here, it's easier for us to diagnose this is just an end-on vessel that we shooting on epi view and taken as lung, look like a lung nodule, but actually it's vessel. If this kind of nodule occur at more periphery region of the lung field, then you need to label as lung nodule rather than end-on vessel. Okay. Granuloma, always outer third of the lung, may be associated with calcification, but end-on vessel in the middle third of the lung, then you easily say it's end-on vessel. Always have a bronchial structure next to it, easy to identify. But if you see this kind of nodule occur at outer 1/3 of the chest of the lung field, raise a suspicion of granuloma or raise a suspicion of lung nodule, doesn't matter. Okay, now we're going to mediastinum quickly. So at the level of T4, T5, you separate from superior or other part of the mediastinum. Then anterior mediastinum is anterior to the heart border, and then medial mediastinum is the heart there. Posterior to it is posterior mediastinum. So these are the boundaries, not talking further. So always remember what structure sitting within the mediastinum so that we can give a list of differential diagnosis when there is some mass arising from any of the mediastinum region. All right, so from lateral, then these are Felsen classification on lateral view, so we just use anterior, then middle or posterior. Okay, but still I like to use this anterior, medial, or posterior mediastinum on if to differentiate on lateral view. Okay, so for the mediastinum cardiocilowate sign, we need to calculate the cardiothoracic ratio. We take the lateral right heart border and the left heart border, and then count with the chest. This is the chest view, right? The widest diameter, not here, not at the level of the heart, but at the widest diameter of the chest wall. Okay, lower a bit, find the widest one, and then you measure. It's a CTR. And then mediastinal position is 1/3 to the right and then 2/3 to the left of the midline. So you will see this 2/3 of the midline, then 1/3 on the right side. And then if there's any widening, if more than 8 cm at this mediastinal region here, if more than 8 cm, if the patient is central with adequate inspiration, raise a suspicion of if there's presence of mediastinal mass, and then higher we evaluate the size, shape, and also the position. So again, to check the cardiothoracic ratio, I think everyone should know from the most lateral border of right and left heart border, and then to the widest chest wall diameter. Okay. So these are the example showing you the mediastinal line and stripe. Um, if we can identify on X-ray, it's good. If not, then it's okay. Because so if we identify the line and stripe here, then if any lesion arising from the mediastinal, we can easily detect. If not, we won't detect actually. All right, because we don't see what we don't know. So posterior junctional line here is the border between the both two upper lobe and the posteriorly, so forming a line here, posterior junctional line. Then the red color is paratracheal stripe, should be thin and nicely delineated just beside the spine. And then azygous esophageal recess, this sometimes, most of the time we don't see this. And then paraspinal line must be sharp and nice here. And then para-aortic line, okay? Look at the aortic and the descending aorta margin. And then this is the epi-window reflection, okay? If there is any obscuration of the line or some lobulated nodule or opacity arising adjacent to the line, always raise the suspicion of and present if there's present of mass or abscesses, okay? Especially at the paravertebral or paraspinal line region here. And then at the paratracheal stripe here is always look, if there's lobulated opacity, always raise a suspicion of lymphadenopathy, as well as at the hilum region here, okay? So for differentiate between any, if the lesion is arising from the lung or mediastinum. So if the lesion arising from the lung, normally they will have a air bronchogram within, and then it will abut the mediastinal surface and create an acute angle, just like in this diagram. So you will see acute angle with the mediastinum and the lung. So if the lesion arising from the mediastinum, you will see a obtuse angle here. All right, but this is acute, this is obtuse angle. All right, then there will be none air bronchogram. So these are example of anterior mediastinal mass or lesion on frontal X-ray. You will see so you can see a mass arising from the mediastinum. Obviously, the mediastinum are widened, and then there's preservation of posterior junctional line. So you can identify the posterior junctional line here. Then anterior junctional line is obscure. Sometimes we cannot find these features. And then silhouette of the right heart border again, obscuring the right heart border, and then the hilum overlay sign is present, meaning we can still see the hilum through the opacity. So that is hilum overlay sign, meaning the lesion sitting in the anterior mediastinum. Okay, so if the lesion is located more lower down here, it will obliterate the cardiophrenic angle. All right, so for middle mediastinum, sometimes it's a bit difficult if we only identify on frontal radiograph, just like in this. So you need to add on a lateral radiograph to see the location of the mass is located at the middle mediastinum. Okay, there will be widening of paratracheal stripe here. Okay, if the mass is higher up, then distortion of zygoesophageal recess and convex border epi-window reflection, this part. But these are very rarely we will use these features to identify a middle mediastinal mass. Always I will just say there's a mass here, maybe from mediastinum or lung, and then always sitting for further evaluation. All right. So for posterior mediastinal lesion, so you will see a abnormal contour of para-aortic line if on the left-hand side, and then distortion of zygoesophageal recesses, and then cervical thoracic sign is the main sign that we use to identify whether it's anterior or posterior. If there's present a cervical thoracic sign, then it's posterior mediastinal, meaning the mass extending beyond and above the clavicle here, posteriorly, then it's posterior mediastinal. All right. I think this one, sorry, this is not what I want to show. So the differential diagnosis is for anterior mediastinal mass, what is sitting in the anterior mediastinal is lymph node. So it's always lymphoma first, and then thymic lesion can be thymoma, hyperplasia, carcinoma, or thymolipoma. These all need to be differentiated on CT scan, or retrosternal goiter if the lesion is extending from the neck going down and then to the anterior mediastinal or germ cell tumor. Teratoma also is a differential diagnosis for anterior mediastinal mass. Middle mediastinal lymph node, again, actually lymph adenopathy, we can always give this differential, or some mediastinal cyst like bronchogenic cyst, the androgenous cyst, pericardial cyst, or neuroenteric cyst, and then aortic arch aneurysm. This enlarged pulmonary artery also can be presented as middle mediastinal mass or any tracheal lesion. These are very rarely we will encounter always lymph node first. Then posterior mediastinal masses are quite common. So even the thoracic descending aortic aneurysm is the posterior mediastinal mass. Otherwise, are the cysts, paraspinal abscess, and neurogenic tumor are the two most common differential for posterior mediastinal mass. All right, lateral meningocele sometimes can happen. Okay, and then extramedullary hematopoiesis in thalassaemic patient, then you will detect as posterior mediastinal mass. Okay, so these are example X-ray showing you the descending thoracic aneurysm. Okay, it's a whole mass here. All right, nobody should miss this findings. Is mediastinal is at least we identify the mediastinal are enlarged here. Okay, then you will see the whole aortic contour is bulky and then following the descending thoracic aorta, so we can confidently say this is a descending aortic aneurysm. Next, refer to hospital, must do a CTA. Okay, if patient is stable, just CTA. If not stable, we need to do a 3-phase study to see if there's any leaking of the aneurysm.
Hello.
Okay, so I need some of you to answer this X-ray. Please put your answer in the chat box.
Anyone? Wait, give them some time.
Oh, anyone still following already 10:00? Still at the chest.
You know, everybody is here. Even the
Yeah.
Facebook also. Okay. Somebody asked a question, but we want to know what is wrong with this. We will answer your question later. How to differentiate consolidation and nodule. Okay. But anyone with this answer? I'm also trying my best. I can't find anything. Is there a mass over the right, the left side in the middle? Left hilar mass. Okay, I also think so. Left hilar mass.
Any more
Anyone else?
answer?
Okay. Somebody said end-on vessel. Anyone else?
I won't show
Hyper-
add-on vessel. I
Class
already showed the add-on vessel just now.
hyperinflated.
Hyperinflated, no. Hyperinflated is normal, so I will show.
Okay. Air
Air
bronchogram on the left.
Air on the left, or we should have air bronchogram on normal, but if not, but it's not within an opacity. Okay, okay. So slight bulky of the hilum here, correct? But what I want to show is the retrocardiac mass here. All right. So these are posterior mediastinal mass, a neurogenic tumor. So always look at the what's that, review area at the retrocardiac. Not sure, right? You see this heart shadow is a bit dense compared to the other X-ray. Let me show again. So like this, right? You can see this heart is like less dense, but this is a mass obscuring, but this is very dense. You can see this lesion. Okay.
Yes.
I go back to some other X-ray. Look at this X-ray. This is a heart shadow, but it's faint opacity. All right. But on this X-ray is very dense compared to the rest. So this one just want to raise the point that always look at the retrocardiac area as review area. Okay. This area is easily missed. First of all, it's just now the lower lobe collapse, the triangular. Okay, the triangular opacity. Next will be this kind of retrocardiac opacity. from lung or from posterior mediastinum. All right. And then another thing with okay. So another thing will be just now so look at this quite fairly normal X-ray. So another thing will be the paraspinal line here. Always review this line because some of the opacity can arise just small bulge here, okay? Just like in this case. Can you see?
Oh, yes.
Okay. Last time, few years back, we missed a small paraspinal abscess in a TB patient. Then the patient come back pain. We didn't do anything. Then after that, the vertebra already destructed. Then only we see retrospectively we trace back the X-ray. Actually, there's already a bulge at the paraspinal. That's why I always remember the case, and whenever I have chance to for CME, I will always show I will always remind everyone must look at the paraspinal line here. Okay, look at the left side is nicely delineated, one line, but this one, if we follow, then we see a bulge here. Okay, if we not following the line one by one, we will miss it, correct?
Yes.
Right, Betty? We will really miss it. Even sometimes we purposely look, also sometimes we may miss it, okay? So must always remember. So this is the paraspinal line opacity, a reminder. Another one is the paratracheal strap here also must be thin and nice. If there is some lobulation, like this paraspinal at this region, always raise a suspicion of lymph node. That might be a first sign for pulmonary TB, presented as a lymph node first, okay? That's always, that's quite common to happen. All right. So now we're going to abdomen X-ray, just a quick one. Identify the gas pattern and then find any extra luminal air, meaning the air is not within the bowel loops, and then any presence of soft tissue masses and also abnormal calcifications. These are interesting one. Okay, so these are normal abdomen X-ray, as you can see. These are unremarkable bowel gas shadow, okay? Always follow the pattern of these are large bowel, and then this is the descending colon, splenic flexure coming down, transverse colon here, and then hepatic flexure coming down, ascending colon. These are fairly nice X-ray. You can see a bowel gas shadow, and then the small bowel always in the middle of the abdomen. After looking at the bowel shadow, the gas pattern, next, to find any extra luminal air, the air will appear as lucency, blackish on X-ray, and then you have to find if there's any abnormal air outside the bowel lumen, okay? Sometimes you will see air in the portal when you will see lucency overlapping with the liver shadow here, or sometimes the air surrounding the kidney in emphysematous nephritis, you will see air surrounding the kidney here, okay? After identify the air, the bowel shadow, you will must always look for the air in the rectum down here, must always have air. And then last, look at the soil shadow, must be symmetrical both sides. Okay, normally can be seen clearly. If it's one part is obscure or bulky, maybe there's some abscess. If both sides is obscure, maybe there's presence of ascites. And always find the stone. Like this case, you will see a stone here. Okay, always follow the kidney shadow and then coming down the ureter tracts along the transverse process and then crossing down to find the stone. Okay, so normal bowel shadow, small intestine, central portion of the abdomen, and then presence of valvular conjunctivitis 1 to 2 cm wide. Sometimes can see, sometimes cannot see. Always less than 3 cm. Then the colon at the periphery of the firm, always less than 5 cm in diameter. If there's dilatation, you will know. All right. So 369 rules, meaning the maximum normal diameter of bowel in X-ray. 3 cm for small bowel, large bowel is 6 cm, cecum can up to 9 cm. So cecum will always located at the right iliac fossa region. Here you can see more dilated bowel loops. If less than that is fine. Okay. Okay, then crescent sign is pneumoperitoneum, air under hemidiaphragm. No one should miss it. X-ray must be taken as PA erect, okay, or AP erect, fine, as long as erect view. So you will see air under the right hand diaphragm. Must always remember to look always on the right hand side actually, because the left hand side we have a gastric bubble, we might mistaken as a pneumoperitoneum. All right, so if present on the right side is definitely pneumoperitoneum, something perforated in the abdomen. Okay, need to inform the surgeon. So these are just an example. Okay, so somebody please answer this X-ray.
Okay, anyone?
Easy one.
Obstructed small bowel.
Yes, stack of coin. Maybe we no need to describe that. Yeah, this is small bowel obstruction. Why? There's dilated loop of bowel at the center of abdomen, and there's multiple air fluid level because this is an erect form. Okay, always remember, look at the form whether it's erect or supine. Normally we will do abdomen X-ray in supine view, but in my hospital they always like to do erect view. All right, so these are small bowel obstruction. Okay, multiple air fluid level with dilated small bowel. Why I say is small bowel? Because there's present a valvular conniventis. Okay, small bowel obstruction. Okay, so these are also features of small bowel obstruction, include string of pearl sign, meaning you will see some small nodules, lucency, sorry, at the superior aspect of the small bowel, because the rest of the small bowel are filled with fluid, so it's already opaque on X-ray, but there's some remaining air locule. It will floating on top of the bowel, so look at a string of pearl. So these are sign of small bowel obstruction, although in this X-ray, you don't see dilated small bowel like the X-ray just now, but these are the sign of small bowel obstruction. We shouldn't miss it. Just like in this case, you don't see dilated, but you will see string of pearl sign is still small bowel obstruction. But when you assess clinically, definitely the patient will have very distended abdomen. Okay. So causes of small bowel obstruction, adhesion, common. If patient have history of surgery, hernia common. So when you look at the X-ray, make sure it's include the inguinal region. All right, you will always find a hernia here, down here, inguinal hernia. Next, malignancy. Most of the time we cannot find on X-ray only. Gallstone ileus is common as well for small bowel obstruction. So gallstone ileus, when it happens, normally you will see opacity like stone at the right iliac fossa, always drop down here, then causing the small bowel obstruction. All right. Then intersubsection in a pediatric patient or inflammatory bowel disease. Okay. These are easy one. What's the diagnosis?
Very easy.
Yeah.
Guys, what's the diagnosis? Everybody's slipping off already.
Slipping off already.
Okay, large bowel obstruction. Yogesh,
Yeah.
is Yogesh a radiology medic MO? Seems to know a lot. Large bowel obstruction.
Yeah, this large bowel obstruction. So why? Because the bowel loop are at the periphery of location of the abdomen, and then there's loss of haustral, so you don't see anything. If valvular conniventis, like in here, this is a small bowel, you will see the line here, valvular conniventis. So this large bowel obstruction. Okay. So what about this specific diagnosis?
Specific diagnosis.
It's also large bowel obstruction, right?
Yes.
It's also large bowel, but what is the diagnosis for this X-ray?
Toxic megacolon.
Okay, maybe, but not.
Okay.
This is specific. Once you see this appearance, only one diagnosis. No differential.
Oh. Sigmoid valvule.
Yeah, this is sigmoid volvulus. Good. Coffee bean sign. Okay. So you will see big coffee bean in the whole abdomen. All right. This is a bean. This is the center of the bean. So this sigmoid volvulus, when the apex pointing towards the right side. All right, good. Sigmoid volvulus, no one should miss this. These are emergency. Okay.
Why is the thing in the middle? Sorry.
What?
This
This one,
yeah.
this one, fecal material.
Oh, I see.
Okay, fecal material like this, like gauze, like that. Okay, so next, rim light identify the calcification also important in X-ray. Sometimes we will encounter. So if rim light, then always maybe surrounding the wall, like in the renal, splenic, or hepatic cyst. But this one also I rarely encounter like some rim light calcification. Aneurysm, if occur at the center of the abdomen, overlapping with the lumbar spine, must raise a suspicion of aneurysm, or surrounding the gallbladder or urinary bladder also. If there's porcelain gallbladder, you will see. Okay. And then this one, calcified hydatid cyst. These kind of images are common in Western country, but not in our country. Okay. So linear tract calcification, like atherosclerotic disease. Okay. Calcification line the aorta, so or line the fallopian tubes. What's different? Sometimes we might see at the pelvis region. Okay, but more commonly in the abdomen aorta. All right, so some are the calcification, like this is the lymph node, calcified lymph nodes, and then calcified fibroids in the pelvis in older women, or even calcified pancreas we might see. Okay, it's just some interesting X-ray to show. So this one is a calculi here at the ureter and also at the right lower pole kidney. So these are urolithiasis. All right. And then this one, anyone can answer? Easy one. Where is a stone? Yeah.
Bladder stone.
Yeah, this is a big bladder stone here. There's also renal stone here. Okay. The bladder stone can really this big, you know, because I have seen a real patient coming with a big, huge bladder stone. Okay. And then some of us miss the diagnosis also because we thought, oh yeah, this is the bladder. We thought it's a bladder shadow. But actually, you shouldn't see any bladder shadow. It really happens. Okay, very funny. So bladder stone,
Very funny.
yeah, is stone. Okay, sometimes we just think, oh, this is a bladder, but actually there's already calcification inside that. Okay, bladder stone plus kidney stone. Okay, what about this?
Anyone? This looks like calcification.
Yeah, now we are in the topic of calcification. How to differentiate bladder stone from a fibroid? Bladder stone, in just like the picture just now, they will have smooth border normally. They will have smooth border. And then calcified fibroids won't occupy at the center of the pelvis. They're always at the side, a bit slight, and then more florid and lobulated.
So
Okay.
Nofahan said this is a calcified uterine fibroid.
These are not too high for the uterine, too high. Uterine is lower down here, pelvis. Okay. So another thing to differentiate the bladder stone is the fibroid, right? Sometimes we look at the fibroid, we always think, is that a stone or not? Fibroid always occur in the pelvis. I think I don't have the images. They will have a oval shape opacity. Okay, for example, this dot, oval shape, and then central will have lucency, and is normally at both sides of the pelvis down there. Then normally that one is fibroid. If really a small bladder stone, not that huge stone just now, normally they will have some irregular margin. All right. But if you always, when you look at the X-ray, we cannot give number one exact diagnosis. Always refer for just ultrasound. You need to refer for ultrasound anyway. Okay, to differentiate whether it's actually fibroid or stone. We are not sure. Okay, we will have additional imaging for the patient. If we can detect the calcification, is good enough for our level. Okay, so what is the diagnosis for this case? No one answer yet.
Yeah, except Nofahan. Nobody want to even
Try.
try? No prize, but no shame. Nobody. Okay.
Nobody. Okay, so Betty, you want to try?
No, I don't want to
You
try.
know? We'll try
Spinal
this
abscess.
one. Okay, spine abscess. No, spine abscess won't show as this calcification. They will always show the small opacity at the
Dubious
side
things
just
is a
now.
bladder mass.
Bladder is further down. This is above the pelvis already. Okay, this is above the pelvis. Yes, A, correct.
Sabrina is correct.
Calcified A. Okay, so see, this is the aneurysm
I
with the
see.
wall calcification. Okay, these are images taken from internet actually, but I've seen in real patient as well. It's really look like this. Okay, so always at the paraspinal region, there's always some interesting findings. Okay, calcified AAA. All right, good. What about this case? These are quite subtle. This is also the review area I mentioned just now for abdomen X-ray.
Okay, anyone? It's getting harder, I feel.
Easy lah, this one. This one you sit further a bit, then you can see. So review area. So this one already cone the X-ray, easy target.
Lee said SBO. I don't even know what's SBO.
Small bowel obstruction, no.
A small bowel.
Small bowel obstruction, you will see dilated bowel lobe at the center, but this there are none here.
Okay, anyone else?
Review area.
Fecal loaded.
Correct, fecal loaded, correct, but it's not pathology.
Okay.
So all these are fecal loaded large bowel. Okay, not dilated.
Calcified.
Calcified pancreas. No, there's no calcification here. No.
Funny, no one in Facebook is answering. Okay.
It's live on Facebook as well. I don't know about that.
Large bowel obstruction.
No, large bowel will occur at the periphery, but I already cone the image, though it's not. Review area for abdomen X-ray. Review area.
Hold on, I need to.
Renal, no.
Okay,
No one.
no one got it.
Okay, compare with this, then you can find the answer.
Compare with this. Osteoporosis.
No, we are at the abdomen X-ray, not the bone.
Okay. Perforated gastric ulcer.
Perforated gastric ulcer. The one I will show you as pneumoperitoneum, but not in this case. The one will look at the chest X-ray. Okay, PGU no. So review a diaphragmatic hernia. Diaphragmatic hernia. I will show you the chest X-ray, but not the abdomen. It will herniated through the diaphragm, so we protruded into the chest wall. Impacted stool, no. Okay, so the answer is psoas. Okay, look at the psoas outline on this normal. You can see clearly, but this one is bulky. Okay, tricky one. All right. Sorry. So this bulky psoas. So always compare both sides of the psoas outline. All right.
Oh, clever.
Okay, so this one small, this one okay, then this is bulky. So highly likely there will be an abscess within the psoas muscle. Okay, so this just to give you a reminder so that we remember to look at the psoas outline when we review the abdomen X-ray. Okay. Okay, what is the diagnosis in this X-ray?
Bladder stone.
Okay, differential.
Anyone? Okay, at least mine is in the differential. I'm so happy.
Yeah, correct.
Obstructed bowel.
Fever, obstructed bowel, no, bowel gas quite good. You will see it's not dilated and just little bit of fecal materials. Normal bowel.
Intestinal.
Fibroid, no.
Okay.
Okay, I
Fibroid.
give you a differential young female patient.
Young female patient.
Young female come in with abdomen pain, acute abdomen. No, it's not a fetus. There's
You do
no
an X-ray with the fetus. So sad, man.
appendicitis. No, I don't diagnose appendicitis on X-ray.
Okay. Okay, this person, first lead. If there is a fetus and we do a chest X-ray, it will be a very sad case because we always ask when is the last menstrual period before we do
Yeah.
X-ray for a lady.
Yeah, ovarian cyst. What cyst?
Okay, what cyst? Ovarian cyst. What cyst?
PCOS? No, no. Dermoid cyst, everyone. There's tooth shape calcification.
I see.
Okay, it's an ovarian cyst. Okay, we twisted ovarian cyst can, but for this X-ray is a dermoid cyst, tooth shape calcification.
Why so in the middle?
It can happen at the side also, but just happen in this X-ray at the middle. Okay, so because the ovarian teratoma, the location of the ovarian quite variable in the pelvis, so the calcification or the tooth can occur anywhere. So tooth shape, the shape of the calcification a bit like tooth, you need to raise a suspicion of dermoid cyst. Okay, good try.
Okay, it's getting more interesting on Facebook because people are trying their luck also.
Okay, so this X-ray finishing soon, but this one just to highlight, whenever we review the chest X-ray and also abdomen, we will always look at the spine, right? So now target on the spine and see if you can find anything on the spine.
Oh, there's a fracture.
No fracture.
Okay.
Actually, this is the thoracic X-ray, but just want to give a reminder to everyone, always remember to look at the spine whenever we review chest and abdomen X-ray. TB spine, no. AS, no.
What's
AS is ankylosing spondylitis.
What's bamboo?
Bamboo sign, also AS, no.
Oh, I see ankylosing. Oh my God.
You've forgotten.
Yes, I've forgotten that word. I have not heard that word for the longest time.
Yeah, bamboo spine.
Oh, I see. I've forgotten. Blinking owl sign.
Yes, good. Right. Which level?
Blinking owl sign. Which level?
Which level?
Nick, which level?
Yes, T11. Yes. Correct.
Oh, where is it? Show me.
So this is the blinking owl. You don't see the pedicle here. Okay. If we don't look and find one by one, we will miss it. So you will always see a pair of pedicle in each vertebra. So this one is missing on the left side. Okay. Then this one also present both side, both side, both side, both side.
Good,
all right, good. So this is always the first sign for presence of bone mats, blinking out sign. Okay, good, Nick, very good.
Oh, in Facebook also, Nithya got it. Kiat Jing also got it. Okay, well done. Nithya did very well. Nithya got teratoma also.
Yeah.
Okay, what else? This is getting
outside. Okay, so always remember to review the spine. Good. Okay, so this is a zoom view for another level. This is winking outside. We don't see the pedicle one side. Must always in pairs. Okay.
Oh.
So what is the diagnosis for this X-ray? Last.
Okay, last one. It's been a long day. Okay. What's the diagnosis for this X-ray? Last one. Anyone?
Anyone?
Fitness.
Anyone at all? Well, give them time. Hold on, let's see whether Nitya can answer.
LBO. The large bowel prominent but not dilated.
Not dilated. 369. Now I can remember.
369.
So this is about 3. Just now somebody asked, when you measure, is it like you just look at it and then take a ruler and measure from the X-ray? Yeah,
You must follow the scale because I use digital, so I can always just draw a line and measure the how many cm.
I see.
Lead
pipe.
No, you can still see haustral within it. Okay, you can still see haustral. It's not lead pipe.
What's lead pipe?
Lead pipe, ulcerative colitis. Lead pipe sign. Loss of haustral, but there's still
Large bowel diverticulum.
Diverticulum. Rarely we will see diverticulum on X-ray. The one specifically on barium edema, then we can see.
Closed loop obstruction.
Wow, no. Very interesting. Bowel ischemia. Why you say bowel ischemia? I will ask this question for you.
Is bowel ischemia a clinical diagnosis, or can it be diagnosed radiologically?
Correlate with the clinically, abdomen distension, acute abdomen, plus if there's bowel dilatation, then we might suggest.
I don't know, Nitya is very good. Is it pneumatosis intestinalis?
Not in this case.
No, okay, no.
Next time I will show you the X-ray for pneumatosis intestinalis.
Diaphragmatic hernia.
Diaphragmatic hernia. Why always say diaphragmatic hernia? No, diaphragmatic hernia I will show it on chest X-ray, but not abdomen X-ray. Diaphragmatic hernia when there's herniated abdomen structure like stomach through the diaphragm into the chest wall, so it's chest X-ray. Okay. Volvulus, no, just now already show volvulus.
Yes. Ascites.
No, no one got it through.
Okay.
Nobody. Nobody. Really, nobody.
Okay, come on, one more guess. Somebody must know. Okay, give us a hint.
Hints. Okay. 18 years old female with acute abdomen. So female always have acute abdomen.
Somebody said perforated bowel, left psoas tumor, left.
No post-op history. Just how old were the female? Just 17 or 18 years old? I forgot. Okay, now 18 years old. 18 years old, female patient, acute abdomen, very pain.
Intussusception.
Intussusception, not in this case. Rib fracture, no, that is a costochondral calcification. All this is not fracture. It's already at the anterior ribs, so that's normal.
Some said toxic colitis.
Toxic colitis, no. A bit prominent, okay lah. Okay, so I give you all the answer.
Drum roll.
Okay. Nobody asked the LMP of this female patient. So there's a fetus in the abdomen.
Oh my God, Lin said fetus, but he didn't say
he didn't answer. Yeah, this is the fetus. You see the spine of the fetus. The spine of the baby. Can you see?
Oh my
This is the
God.
head. This is the head. Okay, this is the fetus. Then this is the femur.
And why did
Alright.
she come with acute abdomen? Because she's,
She pain ma. She never tell that she's pregnant.
oh,
Okay, and then you will see, okay, so there's a gravid uterus, right? So you see all the bowel already displaced periphery, and you see the opacity here. Okay, so we will always, if there's some mass in the center of abdomen, and then the bowel will displace peripherally. So I go back to the previous slide. Let me go back. Okay, for example, okay, this X-ray, you will see the distribution of the bowel lobe is like periphery is the large bowel, then centrally is the small bowel. Okay, but then look at this X-ray. Centrally, there's nothing, no bowel lobe at the center, but all displaced. Okay, so here there's mixture of large bowel and small bowel. So there's a gravid uterus at the center of the abdomen with the baby spine here is a fetus. Okay,
it's quite big already, huh?
quite big already. Third trimester maybe.
Yeah.
Yeah, it happens. So always remember when we request a X-ray, put on the ask the LMP. Must always ask the LMP. If there's no LMP, must always check the UPT. I don't care how old is the girl. Really they won't tell the truth sometimes. Okay.
Oh, I see, because she's a young girl and she's,
Yeah. Sometimes they will say, oh, my period not regular. Then we don't ask further. Correct?
yeah, because
Ah.
we want to, we think, okay, especially if it's of a certain race, we think, okay,
Yeah,
maybe
but
there's no need
it
to
really
ask it.
happens. It really happened. Last time, previous experience, we even did a CT.
Oh,
Inside there's a fetus. CT, not X-ray, that's the worst case. So very scary because nobody asked the FP. We just assume, right? So interesting, right?
yes, very interesting lecture. Really, I enjoyed it a
Okay.
lot.
So this is
Okay.
another fetus. This is even bigger. Third trimester already. This one, you see?
So
Already
Lynn
like
is right
crawling.
when he said fetus. This is already coming out already. I
Yeah,
think the
this
os
is
is
a
open.
this is scary. This is a fetus lah. Okay. All right. I think that's all for today.
Oh, it's a very
Thank you
interesting
very much,
session.
everyone.
Okay, you stop sharing first. Stop sharing first.
Stop
Okay,
sharing.
thank you. I think we can take some question, but before that, I think we will stop recording lah. Okay, we stop recording.